Good evening, everyone. Thank you for joining us at the Epilepsy Foundation New England. We have a wonderful speaker with us tonight, Dr. Ayub. Dr. Ayub is an epileptologist. She focuses on comprehensive epilepsy program at the Rhode Island Hospital. She's got an epilepsy fellowship program director. Her interests are, hold on one second. Sorry. Her interests are diversity, equity, and inclusion, global health, quality improvement, and epilepsy surgery. Her education is from the Warren Alpert Medical School of Brown University, neurology residency at Beth Israel Deaconess Medical Center, Harvard University Neurology Program in Boston, and a fellowship in neurophysiology and epilepsy at Massachusetts General Hospital in Boston. She is a member of the American Academy of Neurology, American Epilepsy Society, American Clinical Neurophysiology Society, member of American Academy of Neurology, American Epilepsy Society, and American Clinical Neurophysiology Society. And with that, I will hand it over to Dr. Ayub. If you do have any questions, please put them in the comments. And at the end of her presentation, we will address all your questions.
Thank you, Amy, for that introduction, and sorry for the mouthful of words. My name is Neishay Ayub. I'm an assistant professor of neurology at Brown University, and I'm very excited to talk with you all today about post-stroke seizures. So just to give you an overview of our talk today, I'll start off reviewing some definitions and tests. Then we'll talk about post-stroke seizures and the risk for epilepsy, how the consequences of those conditions and how we manage them, and then I'll take your questions. I have no disclosures that are relevant to this talk. I do receive some salary support from the National Institute of Health. So let's all make sure we're starting off on the same page. How does the brain communicate? So brain cells talk to one another through electrical messages. A seizure is a sudden burst of abnormal electrical activity that disrupts that normal messaging. The signs and symptoms of a seizure depend on where that abnormal electrical activity is coming from. There's two ways that we define seizures, and we can have focal onset seizures and generalized onset seizures. Focal onset seizures mean that the seizure starts from one spot in the brain. A generalized onset seizure means the seizure starts from the whole brain all at once. Focal onset seizures can present at any age, and often a common trigger can be the presence of a structural abnormality or an injury or damage to the brain, and that could be something like a stroke. Generalized onset seizures often are something that people are born with, but they may arise in childhood, adolescence, or even early adulthood. An EEG is a test that looks at the brain's electrical activity in that moment in time. So it's not a time machine. It can't go back in time and say what happened a few years ago, whether something was or was not a seizure, and it can't go forward in time to say when you'll have your next seizure. It just says in that moment in time, what does the brain's electrical activity look like? And sometimes we see abnormal electrical activity on the EEG, and that tells us that someone's at risk for seizures in the future. And sometimes we can see seizures on the EEG. And sometimes there are some seizures that are so subtle that we can only see them on EEG, and we can't see them without the EEG. MRI is an imaging test. It takes a picture of the brain, it's safe, it's non-invasive, and it gives us a really detailed look at the structure of the brain. MRI can help us diagnose things like stroke, tumors, infections, or inflammation in the brain. And you may all already know how we diagnose this word in this particular definition, but again, like I said, I want us all to be on the same page. So how we define epilepsy is that it's a brain disorder characterized by an enduring predisposition to generate seizures and the neurobiologic, cognitive, psychological, and social consequences of that decision. So with that big definition, how do we as doctors translate that into a diagnosis? So operationally, we define epilepsy as two unprovoked seizures separated by 24 hours, or one unprovoked seizure with a probability that a second seizure will occur at greater than 60% over 10 years. And I want you to remember that 60% when we talk later about post-stroke seizures. So again, epilepsy is defined as either two unprovoked seizures separated by 24 hours or one unprovoked seizure with the risk of recurrence being greater than 60% for the second seizure. When we look at seizures and epilepsy by the numbers, 1 in 10 people will have a seizure in their lifetime, but only 1 in 26 people will develop epilepsy at some point in their life. So, what that means is not everyone who has seizures has epilepsy, but everyone who has epilepsy has seizures. Stroke is the cause of epilepsy in 10% of newly diagnosed adults with epilepsy. And so, what's a stroke? Again, let's take a step back. How does the brain derive its energy? So, the brain's energy source is oxygen, and oxygen is carried through a network of blood vessels throughout the body. A stroke happens when the blood flow to the brain is interrupted or reduced, and that leads to the brain cells not getting enough oxygen, and when they don't get enough oxygen, they become damaged. The symptoms we see related to a stroke is related to where in the brain the damage has occurred. There are two ways that we characterize stroke, and they both relate to how the blood flow is interrupted. In ischemic strokes, the blood flow is blocked by either a clot or a narrowing of the blood vessels. In hemorrhagic stroke, the blood flow is interrupted by a breakage of the blood vessels, and that results in bleeding into the brain. And let's think about the numbers related to stroke. There are over 12 million strokes, 12 million new strokes a year. And so that means there's one stroke happening every 3 seconds. And so in total, there are over 100 million people worldwide that are living with stroke. And 1 in 4 people will have a stroke in their lifetime. And 2/3 of people with stroke, that has occurred under the age of 70. So it's not something that we think of that only occurs in the elderly. There are interventions for stroke, but you do need to, if you recognize a stroke, and we can talk about that later in the talk. If there's concern that you or a family member or a friend is having a stroke, you want to get to the hospital as quickly as possible. Because if you reach the hospital, they would do tests, and if you're found to have the ischemic stroke and which is caused by a blood clot, and if they see that blood clot, there's actually a few things they can do. One is they could give you a medication that could break up the clot, or they could do a procedure where they would remove the clot from the blood vessel. For the clot busting medication, that has to be given within the first 4.5 hours of the stroke. And the manual clot removal has to be within the first 24 hours of the clot being there. And the sooner those medications or that procedure is done, the higher the chance for the brain to recover and for stroke recovery. A third of patients who undergo the clot busting medication will have essentially no symptoms from the stroke itself. So it is something where we always say in neurology, time is brain. You want to get to the hospital as soon as possible. And so now that you have a bit of background on stroke and epilepsy, let's talk about post-stroke seizures. So 10% of stroke survivors suffer from post-stroke seizures. And there's two different types of post-stroke seizures. The first is an acute symptomatic seizure, and the second is a remote post-stroke seizure, also known as post-stroke epilepsy. Acute symptomatic seizures are seizures that occur within the first 7 days of the stroke. Often they can even often they happen within the first 24 hours of the stroke, and that's actually when you're at highest risk for the seizure as well. It's not to be provoked by the metabolic effects of the stroke itself. And if it happens, it can lengthen the stay in the hospital and can lead to worse hospital outcomes. And in about 30% of people who experience an acute symptomatic seizure from the stroke itself, they have a 30% risk of epilepsy. Now, if you remember back to how we define epilepsy, epilepsy is if you've had either two seizures separated by 24 hours or one seizure with your recurrence risk being greater than 60%. If you have an acute symptomatic seizure, your long-term risk for epilepsy is 30%. So we do not start people on long-term anti-seizure medication for an acute symptomatic seizure, because in 70% of cases, they will not go on to develop epilepsy. This is also an area that's currently being studied more and more to see if there's ways that we can predict who become those 30%. The second type of post-stroke seizure is the remote post-stroke seizure, also known as post-stroke epilepsy. So these are seizures that occur more than 7 days after the stroke. The highest risk is actually 6 to 12 months after a stroke. And if you have one post-stroke seizure in this setting where you're outside of that 1 week window, your risk for a recurrent seizure is greater than 60%. And so that's why we consider these patients who have a seizure during this time period to have post-stroke epilepsy. What we find is 84% of people who develop post-stroke epilepsy will do so in the first 2 years of having a stroke. And these are the people that would need seizure medications long term. So I know it's a lot of information about this new concept. And the biggest thing I want you to take away from it is when you compare acute symptomatic seizure to these remote post-stroke epilepsy cases, the difference is when does the seizure occur. If the seizure's in the first 7 days, we can think of that as just related more to the stroke phenomenon itself, and we don't know someone's long-term risk for seizures. If it happens after the first 7 days of the stroke, that's when we worry that someone has a long-term risk for epilepsy and needs long-term anti-seizure medication. There's some risk factors we've identified for those who have post-stroke seizures and epilepsy. One is related to the number and the location of the strokes. If the strokes happen in the cortex or in the larger blood vessels, those are more likely to cause seizures than the strokes that occur in the deeper structures of the brain. The more severe the stroke, the more likely someone will have seizures and epilepsy from it. If someone has acute symptomatic seizures, those again in the first 7 days, also more likely to end up developing post-stroke epilepsy. They've looked at EEG findings within that first 7 days and also the stroke intervention, and it doesn't seem like those are related to epilepsy risk as far as we know right now. So in terms of treatment options, as you're aware, there's over 30 different seizure medications. And the reason being is there's not one perfect one, so we still have to do a similar trial and error of medications for patients with post-stroke epilepsy. you may know this slide or this study well, but this is where we get our numbers related to rates of seizure freedom. And in this study by Kwan and Brody back in 2000, what they did was they studied 470 patients that were previously untreated for epilepsy, and this is epilepsy of any cause. And they looked to see when did they become seizure free with what drug trial. So 47% became seizure free with the first medication they tried. An additional 13% became seizure free with the second medication. And then with the third and multiple drug trials, there was a less than 5% chance that they would become seizure free with subsequent drug trials. And this is the study where we get that seizure freedom rate of 2/3, where we say 2/3 of people will respond to either the first or second medication they try. This is similar to those with post-stroke epilepsy. I would expect the same thing with either the first or second medication we try. We'd hope to control their epilepsy. That study was published back in 2000. They repeated it in 2018, and they found actually similar numbers. So even though over those 20 years we developed more seizure drugs, the rates did not change significantly. And for this next part, I just wanted to review some seizure medications and how we choose them. And I'm not going to go through all 30. I think you'll fall asleep on me. So just going to go through some of the common ones that you may see. So Keppra or levetiracetam. This comes in both an oral and IV form. The most common side effects of it can be fatigue, irritability. It is a medication that is safe in pregnancy. It's one of the ones we consider first line. The nice thing about the pharmacokinetics here is that there's no drug-drug interactions and that this medication is metabolized through the kidneys. They have both twice-a-day dosing as well as an extended release option. Another common medication that you may see used for post-stroke epilepsy or other types of epilepsy is Vimpat or lacosamide. There is both oral and IV available forms of this. The common side effect here is dizziness. Something to keep in mind is that it can affect one's heart rhythm. So often your doctor will order an EKG both before and after you start this medication. This is a medication that goes through the liver and the kidneys, but there's no big interaction with other drugs. It's just one that we'd want to be cautious with using using with other drugs that also affect the sodium channel. The reason being is when we use multiple drugs that work similarly, we're more likely to see the side effects from them. This is also medication that has twice-a-day dosing. Zonegran, also known as zonisamide, has an oral form of it available. The common side effects here can be tingling in the fingertips or a word fog sensation where you have trouble finding your words. This is metabolized through the liver, very few drug-drug interaction, and they have either once or twice-a-day dosing available. Phenytoin or Dilantin is one of our oldest drugs. It has both an oral and an IV form. There are a couple different side effects. When the level is too high, you may notice feelings of dizziness, double vision, trouble with coordination. There are long-term side effects of this medication that you with your doctor would need to monitor over time. One is neuropathy. It can affect the nerves in your hands and in your feet, which can lead you to feeling off balance. It can also affect your bone health, causing osteoporosis. And with that, you'd want to get regular DEXA scans or bone scans with your physician. And it can also affect your gum health, leading to bleeding in the gums. So that's something where you'd want to see a dentist very regularly. This is a medication that also gets metabolized through the liver. There are a lot of drug interaction we have to be mindful of, and one of those is with a blood thinner called Coumadin or warfarin. something that those with post-stroke epilepsy would need to be mindful of. It does have either 2 or 3 times a day dosing, and it's one where we'd monitor blood levels. With all seizures, regardless of what the cause is, there are driving restrictions related to them. In the state of Massachusetts and Rhode Island, if you have a seizure, you can't drive for 6 months afterwards. Once that 6 months is up, then you can start driving again. And you may all be familiar with first aid related to seizure. If you see a seizure, you want to make sure that you stay with the person, make sure that they're safe, place them on their side if you're able to, and also make sure that you take that time for yourself to remain calm. See how long the seizure is going for. If it's longer than 5 minutes, that's when you'd want to call 911. If you see the person's not returning back to their normal self, another time to call 911. If they're hurt in any way, if they're having multiple seizures, it's the first time they're having a seizure, those are other reasons you'd want to call 911 as well. And lastly, just wanted to talk about signs of a stroke. So if you're worried, this acronym here, BFAST, is meant to just kind of give you an overview about big picture things that could be a stroke. So B stands for balance. If all of a sudden, with a stroke, think of it as all of a sudden it comes on. If all of a sudden you're unable to walk, coordinate your movements, have any balance, and you were completely normal the moment before, you would be worried about a stroke. If all of a sudden you have a loss of vision or a change in vision and it doesn't go back to normal, another time to be worried. If there's a sudden facial droop or a change in your facial sensation, that's something that could be a stroke. If you have a sudden weakness in your arm or leg, that could be a sign of a stroke. If you have a sudden change in your speech, either slurring of your speech, trouble finding your words, or trouble understanding what someone else is saying, that could also be a stroke. So if you notice any one of those signs, you really want to call 911 right away and get to the hospital so that you can be evaluated for a possible stroke. And like I said, if they see that you have one of this type of ischemic stroke, there are some interventions that they can do in that case. And so those are all the slides I had today on post-stroke seizures. I always tend to talk too fast. So I can turn it over to you all for your questions.
There are no questions in the chat. If you do have a question, please put it in the chat, or if you want to unmute yourself, you can ask Dr. Ayub directly. Thank you, Dr. Ayub. That was very, very interesting. We do have one question that just came up. What can you share about prenatal strokes? What are some reasons? High blood pressure, perhaps?
Oh, that's a great question. So and with the caveat of I'm an adult neurologist, so I don't see prenatal strokes as much as a pediatric neurologist would. But in terms of causes for prenatal strokes, sometimes they can be related to medications, blood pressure, anything that would cause sort of a dip in oxygen or for the developing brain. Sometimes we can get the perinatal seizures as well, and that could be during the time of delivery. So sometimes it can be difficult to figure out whether was it perinatal at the time of delivery or prenatal as well. But that's also that can be a cause of seizures for pediatric epilepsy as well.
Anybody else have a question?
Yeah, doctor, you referenced the sodium channel. And I was just curious as to what that is and how that works.
Oh, sure. And you know what? Let me find a photo for you. So anti-seizure medications, they actually work by a couple different means. And there's this lovely photo that I'm going to pull up for you. So, so what this is here is it's meant to be a photo of two nerve cells that are communicating with one another. So this is one end of a nerve cell. Can you see my mouse as I'm pointing? Yeah, okay. So this is one end of a nerve cell, and these are the other end of a different nerve cell. So when nerve cells communicate from one another, they can sometimes send messages of excitement, and that's called an excitatory synapse. The synapse just means the space between the two cells. So here we're getting an excitatory message, or there can be an inhibitory message, and that's here at this inhibitory synapse. And seizure medications can work in the presynaptic cell here, or in the postsynaptic cell, or in the synapse in the space between. These blue boxes here are filled with the names of the medications, and then they point to where they're affecting the cell. And so what we can see here is that there's this channel that's directing sodium into a cell, and there's these medications that affect the sodium channel. So sometimes what we see is when people are on multiple medications of the same class, they may more likely have side effects related to that class. So if the side effects of sodium channel blockers tend to be related to dizziness, double vision, trouble with balance, if you are on multiple medications with the same mechanism of action, that could be one of the reasons why you're feeling those side effects. Some people can be on multiple sodium channel blockers and they don't have any side effects, and that's just something your doctors are always mindful of. So this is also our biggest category of seizure medications as well. It's a very common way that we address seizures. But what you can see here is seizure medications can work at a lot of different channels and a lot of different parts of the pre and postsynaptic cell. I can explain this a little bit better. So what happens is an electrical message will come down the presynaptic cell, and it will tell the cell, let's release these vesicles, which are basically a little ball of messages. And what they do is they release these messages into the synapse, the space between, and they can attach to the channel. And when they attach to the channel, they'll send a message down this cell. Sometimes it's a message of excitement. Sometimes it's an inhibitory message. And we have some medications that work more related to preventing that excitation. And we have some messages that are working more towards promoting that inhibition. In both cases, trying to prevent abnormal electrical activity from continuing on. Medications like Keppra work at the vessel and prevent that vessel from opening into that synapse. That was a long-winded answer to your question about what is sodium channel blockers, but I hope that makes sense. I was trying to keep it high level.
Yeah, thank you. That's very helpful.
We do have two more questions. I'm going to ask the second one first, only because it relates to this slide. And then I will ask Wanza's question. The first one regarding this image is from Jordan. Is there a particular neurotransmitter associated with seizure activity?
That's a great question. So, there's not one right way that we found yet with research that will prevent all seizures. And that's why we have so many different seizure medications, and why they work in so many different ways.
Thank you. And our the other question is, how can one explain seizures that stop for 17 years and then restart? Is it some sort of trigger, no accidents or physical injury?
Oh, that's a great question. And unfortunately, I would say it can really, it can be very, very case by case. Everyone's history with epilepsy can be different. So some people will go many years in between seizures. Some people will have a seizure once a day, once a week, once a month, and we have trouble controlling them. So unfortunately, it's hard to know what's going to cause someone's seizure when they've otherwise been seizure free for a long time.
I'll just add, I know for my son, whenever he has a major growth spurt, he'll start with breakthrough seizures. And usually we need to, you know, get blood levels done and check to see where his meds are at and make those changes. But 17 years, I don't know. That's a great question.
Yeah, I was actually wondering, in addition to that, because I also think that's a great question. Some sort of test would probably need to be done on the brain. I would think, I would almost wonder like 17 years ago to see how the brain looked versus 17 years later on the brain, see if there were any significant changes, right? That might possibly give an answer as to why a seizure may have started up again, being 17 years dormant and then start up again, you know? What would like some type of brain scan imaging be able to determine that? I guess is my question related to that.
Or so, unfortunately, there's definitely tests we can do, and oftentimes it's helpful to have baseline testing as well too. So the first time you have seizures and you get connected with your neurologist, we often do baseline EEG, MRI testing. If you've gone 17 years since then, without a seizure, we can repeat those testing, but sometimes we may not be able to find the answer, which I know can be really frustrating. The EEG test, like we talked about, it looks at the brain's activity in that moment in time, but it can't go back in time and say what's happened in those 17 years. Um, and so it can just give you a snapshot, and sometimes that snapshot looks similar to the baseline that you had before. Um, Sometimes it looks different, and we're able to find a particular reason, but I understand it can be frustrating to not have that particular reason as to what's changed. The MRI, especially if you can compare one to something from 17 years earlier, you can see if there's been any structural changes in the brain, and that might be a reason for a seizure. But again, it may look similar to what you had before. Oh, Amy, I think you're muted.
Amy, you're muted. Are you reading the next question?
Yes, thank you. Sorry. This question's from Daryl. Sorry, Daryl. I didn't know I was muted. My panic attacks look and feel like seizures, but there isn't any brain activity. How can I tell the difference between the two?
Yeah, that's a great question. So part, I guess part of it would depend on, so I want to keep it high level, but without asking people to share too much. So some people have seizures that are caused by abnormal electrical activity in the brain. Sometimes people have events that look like seizures, and they're actually caused by a stress or anxiety response. And sometimes people have seizures that are really coming from very deep in the brain, so we can't see them with our traditional scalp EEG, but we can only see them with what's called intracranial EEG, which is when we put the electrodes, surgically implant electrodes into the brain. So, in terms of your question there, part of it would be working with your physician to figure out is if the events that you're having are epileptic seizures caused by abnormal electrical activity in the brain, or are they non epileptic events caused by stress and anxiety? And sometimes when you're able to kind of talk with them and figure out which category you're in, um, then that can kind of help you recognize is the event that you're having a non epileptic event or not.
Jessica Baker asked if a new student has a genetic disorder and abnormal EEG, GABA metabolism issues, no medications at this time. Can you explain this?
I think I would have to know the details of that case more.
Jessica, I don't know if you're willing to share any more of that.
Sure. So I'm an elementary school nurse, and um, we have students with seizures, and they usually have a care plan, or they're working with a neurologist that creates a care plan. And this student, the parents are relaying the information that they don't need medication at this time, and there's no rescue medication, and that they're having episodes that look like seizures, but the parents are saying they're not seizures, and the neurologist relayed to the parents who relayed to me, just follow first aid, basic seizure plans. So there's no Valtoco and there's no Diastat. So I've never come across this before. Usually students have rescue meds. So, and I'm not 100% understanding the GABA, the genetic disorder. It's anyway, those are just a few questions.
Or so I can't speak to
Of course.
genetic disorder. There's unfortunately there's so many. Um, if the neurologist is saying that these events are not so we would not give seizure medications to people who are not having epileptic seizures, meaning seizures caused by abnormal electrical activity in the brain. So it's possible that the event they're having is a non epileptic event, in which case they don't want to over medicalize them by giving medications that um, are not indicated. So seizure medication should really only be used by for events that are caused by abnormal electrical activity in the brain. So I'm guessing that's what it is. Again, speaking in the hypothetical. So with all of these, with all the hypothetical information, I'm just going to give high level without knowing the details. But I will wonder if it's possible for you to talk with the neurologist directly, if that's something, if these events are happening very frequently, or and clarify the care plan in that way. Again, I'm not a pediatric neurologist, but I've talked to employers for my patients in the past too, sometimes with their permission, if that can help clarify things.
Okay, great. Yeah, sometimes it's hard to know if episodes like staring off, or, students that are nonverbal or aren't communicating with staff, and staff are wondering, is this a seizure? Is it not a seizure? By the time they get the tablet out to record it, again, it's a new student. So we're trying really hard to capture these moments that we're like, we're not really sure. Can you show this to the neurologist? It's hard to kind of guide the teachers on what to do when we're kind of wondering ourselves. Anyway, I did reach out to see if we could get some more training at the school.
Yeah, and I will say, there are a lot of events that look like a seizure and are not. So sometimes people have issues related to the heart. For example, they faint, and when they faint, those events look like seizures. Many people who faint will have some shaking involved with it. Like you mentioned, people with some genetic disorders can have staring off spells. Those may be more attentional related rather than a seizure. So sometimes it can be difficult to determine whether something is a seizure or is not when you're just looking at it from the outside.
Jessica, I am the community education specialist at EF&E. So if you haven't already emailed me, make sure you do, and I will set that training up for you.
Great.
We also have a question from Faiza, who's also one of our CHWs. Do you want to unmute yourself and ask yourself, or do you want me to read it, Faiza?
Yeah, I can read it. In people that have brain damage, are the symptoms of a seizure relevant to where the lesion in their brain is? For example, some people smell certain smells when they have a seizure. Would that be relevant to where the where the damage is in their brain?
That's a great question. Actually, it's very relevant. So, where a seizure comes from that's what symptoms it's going to cause. So if the seizure is coming from the temporal lobe, often people may notice, say, a burning smell. They may notice a deja vu feeling, a rising warm sensation in their stomach, sometimes that fear and panic sensation. So those are all things related to the temporal lobe. If the seizure is coming from the occipital lobe, they may see unformed blobs and shapes. And so it's a great question and very much related to where in the brain the damage or the seizure is coming from.
Yeah.
These are all great questions. Any other questions, comments? Dr. Ayub, you've been great answering these as best as possible.
Yeah, you all have had great questions, and so happy to help, happy to answer.
Okay, if there is not any more, we will end early. Dr. Ayub, again, thank you so much for dedicating your time to present this information to us. We really appreciate it. Sorry, just getting thank yous in from the chat, so reading those too. If anyone ever has any questions, you can reach out to me. I did put my email in the chat, and I can direct them to Dr. Ayub if you think of something after. This is recorded. We will be sending out a follow-up email with the recording. So if you wanted to watch it again, you could. Daryl, I had a stroke in the womb. It killed my short-term memory and opened a nerve in brain. Thank you for sharing that with us, Daryl. And as far as the seizure first aid training, myself and Christine Bennett, we do those. Jen does some of those trainings for us as well. She's a new trainer. So if anyone's interested in getting seizure first aid training for themselves, their schools, their companies, please don't hesitate to ask. Dr. Ayub, do you have anything else to share?
No, just thank you to everyone for sharing their stories and coming to the talk today. It was nice chatting with everyone.
Great, thank you. Good night, everyone.
Take care.